Assalamu alaikum. Today we are starting our new series of lectures on the diseases of the respiratory unit. These include asthma, COPD, and pneumonia. The material for this unit has been taken from Medical Diagnosis and Management by Inam Danish, Lippincott Illustrated Reviews Pharmacology, and Clinical Pharmacology and Therapeutics by Roger Walker. I am Shoaib Mohammed, lecturer in the Department of Pharmaceutics, Faculty of Pharmacy, University of Sindh. So firstly, we are starting with asthma. This is the outline for discussion on asthma. This includes introduction of asthma, epidemiology, its etiology, pathophysiology, clinical manifestations, investigations, and treatment. So asthma is a chronic inflammatory disease of the airways that is characterized by episodes of acute bronchoconstriction. That means the bronchioles are narrowed down in asthma, and this narrowing down of the bronchioles will cause shortness of breath, coughing, chest tightness, wheezing, and rapid respiration. Globally, it has been estimated that around 300 million people are currently suffering from asthma, and 1 in every 200 deaths worldwide have been attributed to the asthma. In Pakistan, it is estimated that about 4.3% of the population is suffering from asthma. In etiology, there are two main causes of asthma symptoms. These include airway hyperresponsiveness and bronchoconstriction. In airway hyperresponsiveness, there is an increased tendency of the airway to react to the stimuli or trigger to cause an asthma attack. That means there may be an external stimuli that will be causing an irritation to the respiratory tract, and there will be hyperresponsiveness of the respiratory tract. However, in bronchoconstriction, there will be narrowing of the airways that cause airflow obstruction. The table shown here shows the various triggers that cause the asthma. Like the allergens include the pollens, molds, house dust mite, animal dander, animal saliva, and animal urine. The industrial chemicals may include the manufacturing of isocyanate containing paints, epoxy resins, aluminum, hairsprays, penicillins, and cimetidine. The drugs that can cause asthma or exaggerate asthma include aspirin, ibuprofen, prostaglandin synthetase inhibitors, beta adenoreceptor blockers. The food products that may cause asthma include nuts, fish, seafood, dairy product, food coloring, especially tartrazine, benzoic acid, and sodium metabisulfite. The environmental pollutants include traffic fumes, cigarette smoke, sulfur dioxide. Other industrial triggers may include the wood or grain dust, colophony in solder, cotton, dust, grain weevils, and mites. The miscellaneous factors that may cause asthma can include the cold air, exercise, hyperventilation, viral respiratory tract infection, emotion or stress. Swimming pool chlorine can cause asthma. The asthma causes the airflow obstruction, and this airflow obstruction is basically due to the bronchoconstriction. In normal situations, the bronchioles are dilated and there is minimum fluid present inside the bronchioles. However, in certain triggers, there may be contraction of the bronchial smooth muscles that will cause narrowing down of the bronchioles. There may be inflammation of the bronchial wall that will cause the swelling of the bronchial wall, and eventually the lumen of the bronchial tree will become narrowed down. And in some situations, there will be also the secretion of the mucus that will also cause more narrowing down of the bronchiole, and eventually less of the air will be moving through the lumen. Now, based on the causative factors that are causing the narrowing down of the bronchioles through inflammation or secretion of the mucus or bronchoconstriction, may be extrinsic or intrinsic. If the factors are extrinsic, we call it the extrinsic asthma, which more often occurs in children and is basically due to the allergens. However, in intrinsic asthma, more often develops into the adults and is non-allergenic. That means there may be some internal pathology involved into the bronchoconstriction. Mostly, the clinical symptoms of asthma may manifest as persistent cough, but most commonly, it is described as recurrent episodes of difficulty in breathing, which is associated with wheezing, that is a high-pitched noise due to the turbulent airflow through a narrowed airway. Status asthmaticus is a type of asthma and is a severe condition in which one asthmatic attack follows another without pause. In clinical investigations of asthma, the most useful test for abnormalities in airway function is the forced expiratory volume. This is measured by means of lung function assessment apparatus such as spirometer. In this diagnostic test, the patient takes a deep breath and blows as hard as possible into a tube. The technician monitors and encourages the patient during the test, while the machine records the results of the respiratory test. Now the treatment of asthma. The pharmacological management of asthma depends upon the frequency and severity of the patient's symptoms. If infrequent attacks are present into a patient, they can be managed by treating each attack. However, if there are more frequent attacks present in the patient, a preventive therapy may need to be used. Now, this table shows the classification and treatment of asthma based on to the frequency and severity of the symptoms. The asthma can be divided into intermittent, mild persistent, moderate persistent, and severe persistent asthma. In intermittent asthma, there are less than 2 days per week of asthma attacks. The forced expiratory volume or expiratory test is near normal. In intermittent asthma, there is no long-term control medications given. However, for the quick relief of the asthma attack, short-acting beta-2 agonists may be given. Secondly, in the mild persistent asthma, there may be more than 2 days per week asthma attacks, but there will be not daily attacks into the mild persistent asthma. Again, similarly, the spirometry or forced expiratory volume in mild persistent asthma is near normal. For the long-term control of the mild persistent asthma, low-dose inhaled corticosteroids will be given, while for the quick relief of symptoms, short-acting beta-2 agonists are given. In more severe type of the asthma called as the moderate persistent asthma, there will be daily attacks of asthma present into the patient. The forced expiratory volume or spirometry will be 60 to 80% of the normal. In moderate persistent asthma, low to medium dose inhaled corticosteroids and long-term or long-acting beta-2 agonists are administered. Again, for the quick relief of symptoms, short-acting beta-2 agonists can be administered to the patient. Finally, for the severe persistent asthma, the patient will be having continual asthmatic attacks on daily basis and the forced expiratory volume or spirometry will be less than 60% of normal. In severe persistent asthma, high doses of inhaled corticosteroids and a long-acting beta-2 agonist is administered. Similarly, as with the other situations, for the quick relief of symptoms, short-acting beta-2 agonist can be administered. Here is the pharmacological classification of the different classes of the anti-asthmatic drugs that are used. Number one are the beta-2 adrenergic agonists. These include the short-acting beta-2 adrenergic agonists, and long-acting beta-adrenergic agonists. The SABAs include the albuterol and levoalbuterol, while the LABAs include the salmeterol and formoterol. The second class, the commonly used class, is the corticosteroids. These include the beclomethasone, triamcinolone, mometasone, and fluticasone. In certain other situations, if the asthma cannot be controlled with beta-2 adrenergic agonists or corticosteroids, the leukotriene modifiers can be given. There are two major subdivisions of the leukotriene modifiers that include the 5 lipoxygenase inhibitors that include the zulitron and cystinyl leukotriene 1 receptor antagonists that include the zafirleucast and monteleucast. Finally, we can also use the anticholinergic drug ipratropium through inhaler. The beta-2 adrenergic agonists are one of the widely used drugs in the treatment of asthma. They are directly acting onto the bronchial smooth muscles and causing the relaxation of the bronchioles, thereby helping in the easy movement of the air into the lungs. They are used into the quick relief of the symptoms, as well as they can also be used as an adjunctive therapy for long-term control of asthma disease. The beta-2 adrenergic agonists have been divided into short-acting beta-adrenergic agonists and long-acting beta-adrenergic agonists. The short-acting beta-adrenergic agonists produce rapid onset of action in 5 to 30 minutes and provide a relief of 4 to 6 hours. Like salbutamol, 200 microgram when required can produce the effects in 5 to 30 minutes and that may last for 4 to 6 hours. The long-acting beta-adrenergic agonists like salmeterol and formoterol are chemical analogues of the albuterol. The LABAs can provide bronchodilation for at least 12 hours. The adverse effects include the tachycardia. That means they should be carefully giving to the heart patients because they may also act onto the beta-1 receptors onto the heart. They may cause hyperglycemia by affecting the beta cells into the pancreas. They may cause hypokalemia and hypomagnesemia. The corticosteroids are drugs of choice for long-term control in patients with any degree of persistent asthma. They decrease the bronchial inflammation by inhibiting the release of arachidonic acid through phospholipase A2 inhibition. The inhaled corticosteroids are more preferred as compared to the oral corticosteroids because they produce less adverse effects. In status asthmaticus, intravenous methylprednisolone or oral prednisone can be administered. The inhaled corticosteroids may deposit in oral and laryngeal mucosa and cause oropharyngeal candidiasis due to the local immune suppression and may also cause the hoarseness. To overcome this problem, the patient should be instructed to rinse the mouth in a swish and spit method with water or brushing teeth after inhalation. The table here provides the list of the drugs other than the corticosteroids for the treatment of asthma. First is the formoterol that can be given into the inhaler form in the age group of 6 years to the adults in the dose of 12 to 24 microgram twice a day. The ipratropium bromide can be given in inhaled form in the age group of 12 years to the adults in the dose of 20 to 40 microgram 3 to 4 times daily. While into the nebulized form for acute bronchospasm, it can be given to the adult at a dose of 500 microgram repeated as necessary. The salmetamol can be given in inhaled form in the age group of 5 years to the adults in the dose of 200 microgram when required up to 4 times a day. While nebulized form for acute bronchospasm can be given to the adults in the dose of 2.5 to 5 milligram repeated as necessary. The salmeterol can only be given into the inhaled form into the age group of 12 years to the adults in the dose of 50 to 100 microgram twice a day. The terbutaline can be given in inhaled form in the age group of 5 years to the adults in the dose of 500 microgram when required, or up to 40 times a day. The nebulized form for acute bronchospasm, the terbutaline, can be given to the adults in the dose of 5 to 10 milligram repeated if necessary. The theophylline can be given orally to the age group of 12 years to the adults in the dose of 175 to 500 milligram twice a day. Now this table enlists the corticosteroids that are used in the treatment of asthma with their standard dose and high dose. Firstly, the beclomethasone dipropionate or budesonide can be used in adults in the dose of 100 to 400 microgram twice a day. It's a standard dose, while at the higher dose it can be used at 400 to 1000 microgram twice a day. In the age group of 12 to 18 years, it can be used as a standard dose of 100 to 400 microgram twice a day and 400 to 1000 microgram twice a day at a highest dose. In the age group of under 12 years, the standard dose is 100 to 200 microgram twice a day and the highest dose is 200 to 400 microgram twice a day. The second drug is the cyclosonide that can only be used into the adults and its standard dose is 80 microgram once daily, while its highest dose is 160 microgram once daily. The fluticasone can be given into the adults. Its standard dose is 50 to 200 microgram twice a day and its highest dose is 400 to 1000 microgram twice a day. For the age group of 12 to 18 years, the standard dose is 50 to 200 microgram twice a day and the highest dose is 200 to 500 microgram twice a day. For the age group of 4 to 12 years, the standard dose is 50 to 100 microgram twice a day and the highest dose is 100 to 200 microgram twice a day. The last drug in this class is mometasone that can be given to the adults as a standard dose of 200 to 400 microgram once daily and the highest dose of 400 microgram twice a day. The mometasone can be given in the age group of 12 to 18 years in the dose of 200 microgram twice a day or as a highest dose up to 400 microgram twice a day. The leukotriene B4 and cystinyl leukotrienes LTC4, LTD4 and LTE are products of the 5-lipoxygenase pathway of the arachidonic acid metabolism. The 5-lipoxygenase is found in mast cells, basophils, eosinophils and neutrophils. The LTB4 is a potent chemotectant for neutrophils and the eosinophils. The cystinyl leukotrienes constrict bronchial smooth muscles, increase endothelial permeability and promote mucus secretion, thereby causing narrowing down of the bronchioles. The leukotriene modifiers decrease these effects and cause bronchodilation and decrease the symptoms of asthma. The leukotriene modifiers are given orally and are useful in the treatment of asthma when the asthma is poorly controlled by the conventional therapy like with the SABAs, LABAs and the corticosteroids, or the patients are feeling adverse effects secondary to the administration of the corticosteroid treatment. The adverse effects of the leukotriene inhibitors include the elevations into the serum hepatic enzymes, headache and dyspepsia. The other anti-asthmatic drugs include the cholinergic antagonists, which include ipratropium, which is a quaternary derivative of atropine. It is given through inhalation and it is not absorbed into the systemic circulation due to the quaternary structure. It may be useful in patients who are unable to tolerate short-acting beta-adrenergic agonists or patients who are having COPD along with asthma. Their adverse effects include the xerostomia and bitter taste because of their local anticholinergic effect. The other agent that is used in the treatment of asthma is theophylline, that is a methylxanthine derivative and is a neurotherapeutic index drug, and lessly preferred into the treatment of the asthma. It causes bronchodilation with an unknown mechanism. The other drugs include the omalizumab, that is a recombinant DNA-derived monoclonal antibody, and it selectively binds to human immunoglobulin E that may be involved into the inflammation of the bronchioles and causing the asthma, thereby inhibiting its action and relaxing the bronchial smooth muscle. The last agent is the cromolyn. Cromolyn is an effective prophylactic anti-inflammatory agent. Cromolyn inhibits mast cell degranulation and the release of the histamine, eventually decreasing the allergic effects. The UL dose is 20 mg via nebulizer 4 times a day at regular intervals. Finally, we conclude our lecture with this video.
It starts with a cough or a wheeze. Soon, your chest feels tight. Your breathing speeds up and gets shallower, making you feel short of breath. These are common symptoms of an asthma attack. Around the world, more than 300 million people suffer from asthma, and around 250,000 people die from it each year. But why do people get asthma, and how can this disease be deadly? Asthma affects the respiratory system, particularly the smaller airways, such as the bronchi and bronchioles. These airways have an inner lining called the mucosa that's surrounded by a layer of smooth muscle. In people with asthma, the airways are chronically inflamed, which can make them hyperresponsive to certain triggers. Some of the many asthma triggers include tobacco smoke, pollen, dust, fragrances, exercise, cold weather, stress, and even the common cold. When people with asthma are exposed to these triggers, an asthma attack or exacerbation can occur. But how exactly do such everyday factors lead to an asthma attack? If an asthmatic is exposed to a trigger, the smooth rings of muscle that circle the small airways in their lungs contract and become narrow. Simultaneously, the trigger worsens inflammation, causing the mucosal lining to become more swollen and secrete more mucus. Under normal conditions, the body uses this mucus to trap and clear particles, like pollen or dust. But during an asthma attack, it blocks the narrowed airways, making it even harder to breathe. These effects lead to the symptoms of asthma. Smooth muscle constriction results in the feeling of chest tightness. Excess mucus and increased inflammation can cause coughing, and the wheezing noise? That happens because as the airways constrict, air whistles as it passes through the narrowed space. These symptoms may make a person feel like they're running out of air. Yet counterintuitively, during an asthma attack, the inflammation can make it harder to exhale than inhale. Over time, this leads to an excess of air in the lungs, a phenomenon known as hyperinflation. The trapping of air inside the lungs forces the body to work harder to move air in and out of them. Over time, this can lead to reduced oxygen delivery to the body's organs and tissues. Sometimes, in untreated severe asthma attacks, the body can't keep up, which can lead to death from lack of oxygen. So how do we prevent these uncomfortable and potentially fatal attacks in people who have asthma? One way is to reduce the presence of triggers. Unfortunately, the world is an unpredictable place, and exposure to triggers can't always be controlled. This is where inhalers, the primary treatment for asthma, come in. These medications help asthmatics both control and prevent their asthma symptoms. Inhalers transport medication along the affected airways, using a liquid mist or fine powder to treat the problem at its source. They come in two forms. There are reliever medications, which treat symptoms immediately and contain beta agonists. Beta agonists relax constricted muscles, allowing the airways to widen so more air can travel into and out of the lungs. The other form of inhalers serve as preventive medications, which treat asthma symptoms over the long term and contain corticosteroids. Corticosteroids reduce airway sensitivity and inflammation, so asthma can be kept under control. They're also crucial in preventing long-term damage from chronic inflammation, which can cause scarring of the airways. Inhalers are known to be very effective and have helped many people live better lives. Although we've come a long way in improving how we treat and diagnose asthma, we still don't know its exact causes. We currently believe that a combination of genetic and environmental factors play a role, potentially acting during early childhood. Recent research has even linked poverty to asthma incidence. This may be due to reasons ranging from exposure to additional pollutants and environmental irritants to difficulties in obtaining medical care or treatment. As our understanding of asthma improves, we can continue to find better ways to keep people's airways happy and healthy.